All right. So today I got Scott Epsley on again. He's currently the director of player health and performance at New York Gotham, and he used to be the medical director at Philadelphia Sixers. So Scott, can you introduce yourself a little bit?
For sure, Eric. Yep. As you just said, am the director of player health and performance at Gotham FC in the National Women's Soccer League, and got to working with those players through working with a bunch of US women's national team players that I'd been consulting for. Prior to that was, as you also correctly alluded to, medical director at the Philadelphia 76ers, and I worked at Georgetown Athletics as well in Division One college athletics. Originally from Australia, we work with national teams and professional athletes, a couple of professional teams there before moving to the States in 2008. And since then, as I said, had worked in Division One college athletics, consulted with a bunch of professional teams in DC, which I consider my hometown, and still have a place down there and very dear to my heart before making the move to Philly and then becoming a private consultant, working with a bunch of individual players, teams, doing injury audits. Uh, Also have a bit of a research side, and we're going to talk about some of that today, I think. We've been really digging into some of the more recent NBA injuries, very popular to talk about Achilles tendon ruptures and the likes, but also looking at ACL injuries in the NBA, among other things.
Nice, nice. So, man, uh, shout out to Adam Perry, because every time talk about you, he said like you are probably the one of the smartest people he ever know. And like after the last podcast we did, I really feel like, man, you are like really smart. So, uh, the first thing I want to ask is like, recently you and Evan like published a paper about prior injury leading to Achilles tendon tear. Can you like kind of share your thoughts on that and what exactly is that paper talk? Does that paper talk about?
Yeah, so the genesis of this was I did an injury audit for an NHL team. And one of the things that I observed was that there was a series of small time loss injuries that led to much larger time loss injuries in quite a high proportion of the injuries that that team sustained over the course of a season. And Adam and I got to talking about this, and we had previously studied the mechanism of Achilles tendon rupture and mechanism of ACL rupture in NBA players. And we said, well, I wonder if, there is kind of a series of injuries that we could identify that seem common to these injuries that precede them potentially. And so we set about using publicly available databases and shout out to Randy Forbes, computer scientist, who really helped us scrape all of this and put a massive database together, who was instrumental in our research and really then dug into analyzing this data.
So, uh, what are those like main like injury that lead into uh Achilles tendon tear?
Okay, so previous conventional wisdom had been that if you have Achilles tendonitis, you're not likely to go on to rupture your Achilles tendon. And our research actually debunks that a little bit. So, generally speaking, two-thirds of people who go on to rupture their Achilles tendon did not have previous Achilles tendonitis was the previous published research, but it was pretty old. We found 35% of players who went on to rupture their Achilles tendon in the NBA had previously missed time to Achilles tendon pain. We don't really know all the ins and outs of what that means because it's, again, publicly available data, which is, a little bit frustrating, but we know that they had missed time due to Achilles tendon pain. And much of those was in 90 days leading into the injury.
So, with all the injuries right now, all the injury happening right now, um, I want to start by asking like when it comes to like tendonitis, tendinopathy, or even like patella tendon tear or Achilles tendon tear, like most like everybody basically talk about isometric, right? So, and when I talked to Adam about this, he said like you kind of have a different thoughts on like how to treat each tendon or how to train it. Can you just like share thoughts on that?
Yeah, I think it's different treating a pathologic tendon to training a potentially normal tendon. Although, again, if some other research that we presented at the NBA Combine on patella tendinopathy, we did a G League study with the NBA, looking at tracking patella tendons over the course of a G League season. We start out with 40 players. I think we ended up with about 31 or so by the end of it. And what we found was about 80% of those actually have pathological changes in their tendon, no matter what. So we know that a high proportion of our basketball players, particularly the patella tendon, and we're going to expand this potentially moving forward, looking at the Achilles tendon and also looking at developmentally, including some of our soccer colleagues. But we know that there are changes within these tendons, whether they're symptomatic or asymptomatic in our basketball players. So the first thing is, looking at a painful pathologic tendon versus training ostensibly normal tendon that does not have pain is probably two different things. I personally use isometrics to manage pain. You can use it to get a little bit of time under tension as well, and there's some value to that. But I think it's really important to understand the structure of the tendon. It's not all about trying to build collagen in the tendon. And in fact, we know from Sean Docking's work that pathologic tendons often have more normal collagen when you look at them under UTC, ultrasound tissue characterization, than do normal tendons. And I've actually seen that in NBA basketball players and in NBA basketball players who have been told, oh, you need to go and have surgery because you've got 40%, tear in your tendon or 40% of severe pathology in the collagen structure of your tendon. The thing is, when you actually compare it to their normal side, they've got more normal tendon than they do on their normal side. And I've seen this, in a number of occasions. So I think, painful pathologic tendons, managing pain with isometrics is helpful. But we have to go on to consider all of these other, causes or pathomechanics and pathoetiology within the tendon. And so we know that interfascicular gliding, the gliding of the tendon in the matrix, the extracellular matrix in between the tendon fascicles is really important. And that may be more important even, within tendon bundles, within the quadriceps tendon, for instance, where the whole tendon bundles actually have to move on each other from the VM contribution to the RF to the VI and the VL contributions within that tendon. And so in basketball players, for instance, we see a lot of pathology in the quadriceps tendon, vascularization, calcification, but we actually don't see a lot of symptoms. And it may be that that's because of where it is within the tendon and the way those tendon bundles glide on each other versus intrasubstance changes that we see in the patella tendon that may be more symptomatic. So, when we think about how the tendon generates force, it's also through the viscosity of that tendon and that intrafascicular gliding and the matrix and the quality of that matrix and the tendon's ability to rapidly generate tension in like a spring and then to return that energy. So if we're only training isometrics, for instance, and I think this is where people go wrong, we didn't just find that Achilles tendinopathy or Achilles tendon pain was a precursor to injury. We found that other injuries like ankle injuries and foot injuries, calf muscle strain, which we just saw in the case of Halliburton. We'd also seen in the case of Kevin Durant several years ago when he was at Golden State, were precursors. And so I think sometimes what happens, we've also seen this in ACL. We have another paper that is under review right now, and where we've seen, knee injuries, other injuries, preceding ACL injuries. Um, I talk to practitioners that work with elite athletes, and they say, well, we were working on that, we were training that. Well, what were you doing? We were doing isometrics, but that's not enough to maintain the spring-like function of the tendon. And so we have to think about, all of the things that this tendon has to do. And so for me, when I'm thinking about, training a tendon that's still relatively normal, potentially because an athlete's out with a different injury or another injury, how can I get some of those types of mechanical requirements through that tendon while they're out with whatever this other injury is also an important consideration. And that includes, that kind of amortization, that concentric eccentric turnaround where the tendon acts like a spring. It includes training the tendon in different positions. It includes getting heavy load through range on the tendon, in all of these features. And so the challenge for the practitioner is really figuring out how to do that effectively, especially when an athlete's out with another injury, because, I think these structures detrain very, very quickly. And I think that's something that, is probably a little bit or underrated or underregarded within our sports medicine community. And I think we can do a better job of maintaining that when an athlete's out with a different injury.
Cool, cool. Man, my mind exploding right now. It's like only like 10 minutes in. So, um, bear with me right now because this is all new to me. So I'm gonna ask like really stupid questions. So, um, if we're talking about like those tendinopathy or with tendon pain, you say you're gonna treat it with isometric. So outside of isometric, what else would you do with those like pain tendinopathy or
Yeah.
tendonitis?
Yeah. So I'm going to use isometrics to manage the pain, and it's usually where I might start every day, right? Just to get some pain relief so that we can then do some other things through range to continue to, or whatever else we need to do with this player, whether it's they do some running, whether it's, basketball and they do some shooting, and so, whatever we're doing with them, we're going to manage the pain that way. In season and out of season is a little bit different. In season, you're obviously trying to prepare game to game. The density of games limits some of the other things that you can do. You're getting the plyometric element from just playing the sport. So you're managing it, that way. And so you're not adding plyometrics because the player's already doing the plyometric component in the act of playing. Out of season, you're not getting that, so you need to add that. But my typical progression is going to be isometrics, then going through some really heavy, heavy load as much as I can through range isotonics, then adding, the eccentric kind of turnaround phase. So really getting that spring-like mechanism and backing the load off initially and training that. Adding the kind of deceleration element, obviously depending on the tendon and how we're doing that, and then adding the plyometric element so that we're getting that. So I typically go through that process in one way, shape, or form. And I mean, when I'm consulting for players and people send me, cases, uh, there's no recipe, unfortunately. There's a general kind of construct, and it's different for different tendons. And how I load a quadriceps tendon is very different to how I load a patella tendon because of the different rectus femoris elements and the different ranges of motion that we typically get quadriceps symptoms in. But the principles remain the same. I think that it's also the tendon will talk to you, and Jill Cook talks about this. I talk about this, and I think if you listen to the tendon will talk to you. The hard part about giving somebody a program from afar is that you don't have the benefit of seeing how that tendon responds the next day or within that 72-hour period. And we know that 72 hours is kind of the peak response of the tendon. So, really listening to how that tendon is responding tells you what to do next. And if you overdid it, then you'll know and you'll see how that tendon has responded. And you can say, all right, this was a little bit too much. We need to back off. We need to, in what way, shape, or form back off, whatever that means. But, it's really hard to just give a recipe from afar for this is how you manage a tendon because it's a constant act of just giving something a stimulus to the tendon, seeing how the tendon responds to that stimulus. Can I push a little bit further? Can I push a little bit harder? Nope, I've overdone it a little bit with that stimulus. I need to back off. The other thing I say about tendons is typically tendons will tolerate the higher intensity stuff over the volume stuff. And so, if we're thinking like in the Achilles, for instance, I'll often do kind of short run throughs and things like that at a higher intensity before I'll start adding volume runs in. Whereas that is probably the opposite of how a lot of people would manage it. But the tendon will actually tolerate that, typically just short little bouts of intensity.
Cool, cool. Because although Adam kind of said that there's different way to like load different tendon, and it's not just isometric like you mentioned. But I really feel that last summer when I had really bad like patellar tendon pain. I was doing all the isos, like literally everything I can do. Like I did isometric every single day, and it just didn't work, right? And I finally go to another PT in Taiwan and help me get the relative motion between my femur and tibia, and that finally releases my pain. And I can just do like uh uh running, sprinting, jumping, anything like without pain. So, uh, how important is like the relative motion of the part like between like femur and tibia, and maybe also the ankle joint?
So a couple of things there. Firstly, is a lot of patella tendinopathy, is misdiagnosed. We're dealing with patellofemoral pain a lot of the time, and so many times I see a player who's referred to me who has actually got patellofemoral issues, and it's mimicking it. Little anecdotal story. As much as I know about tendons, this is how much a patella or patellofemoral joint can mimic patella tendon pain. I was on my way to see a player at the NBA Players Association. I was living in New York and I take the subway over there and I'm running up the subway stairs to get up there. I was running a little bit late. And as I do, I get this horrible sharp stabbing pain right in my patella tendon. And I was like, oh God. And now I'm kind of like limping. I was supposed to get on court with this player and do some stuff on court with him, work out with him. And I was like, oh man, I'm not going to be able to do this. Like, what did I do? And in my brain, I'm like, there's no way I hurt my patella tendon. But my body is going, your patella tendon hurts, your patella tendon hurts, your patella tendon hurts. And so, I stupidly scan my patella tendon with ultrasound because that's what I do, and of course my patella tendon is perfectly normal, and it's patellofemoral, and I have a long history of patellofemoral stuff from playing basketball. So I use that anecdote to pinpoint that even somebody like me who knows so much about this and knows that it's likely patellofemoral can your brain can almost convince you that it's not. So firstly, we have to get the right diagnosis. In terms of, tibia and femur, and a lot of those like tibiofemoral rotation control, fibular head position, we often see people in external tibiofemoral rotation, anteriorly translated fibular head, or different things like that happen, from a soft tissue standpoint. Making sure that we get popliteus control, tibiofemoral control. You alluded to the ankle joint, and that obviously doesn't just come from the talar crural joint. We all know the potential the one volleyball study that showed that talar crural dorsiflexion decrease was linked to patella tendon pathology, but or patella tendon pain, sorry, patella tendinopathy. But it's only one piece of the foot and ankle puzzle, and so making sure that everything through that subtalar joint midfoot is working, and especially in our basketball players, that's often a very dysfunctional part of the anatomy. So it's all important, but I don't think any of that trumps the way that we load the tendon, or in the case of patellofemoral joint, how we load the patellofemoral joint, which is very different to how I would load a tendon.
Nice, nice. So, um, going back to tendon, uh like you mentioned, like different tendon have like different structure and the way you load it would be different. So can you kind of give me an example like uh if it's both like have symptom with pain, how would you load a patellar tendon and like what would be the difference between loading a Achilles tendon?
Yeah, so well, again, I also think we need to look at where the tendon pathology most likely occurs, right? And so if it's insertional, it's going to be different. We haven't even touched on insertional tendinopathy, but we do see that a lot in basketballs around the Achilles tendon. Actually, probably more common than the mid-substance stuff in the Achilles, has been my experience. So insertional stuff, you're going to avoid those ranges of dorsiflexion, especially early in the rehab, and maybe you're getting to add them later on down the track. But you're really, looking to avoid those. You're working in pain, not necessarily pain-free ranges, but in less symptomatic ranges, as close to pain-free as you possibly can, and then gradually working into those painful ranges. And we found in our study that, high levels of ankle dorsiflexion were a feature. Now, it's very hard to know the exact point of rupture, right? But their feature of rupture, we were in excess of like 47, 48 degrees of ankle dorsiflexion, which is a lot. Most basketball players that I've screened have 30 to 35 degrees of ankle dorsiflexion. We know that goes up a bit when they get warm. There's a couple of studies looking at pre and post exercise. You maybe get a bump of about 5, but we're still very, very end of range and in knee extension. So, the actual, series elastic element through the calf is right on stretch. So we're really trying to teach a player to avoid getting into those end of range positions with the Achilles tendon. We want them to have a stiff foot. We want them to have a stiff ankle. We want them to be able to perform that false step without letting that heel drop to the floor and get into that like ladder degrees of ankle dorsiflexion. So everything that we're doing training wise is really going to be geared toward that, especially the end stage rehab, is how do we retrain, that type of explosive move without letting that foot collapse, that ankle collapse into those ranges, and having good midfoot control and good foot intrinsic and foot stiffness as well is super important there, also. Um, Take that to the patella tendon, where it's kind of, very much more about the deceleration elements, right, of the patella tendon and how that works. Uh, Very close to the inferior pole, so deeper ranges of knee flexion are likely to create some symptoms. We now also have this theory of kind of, pressure within the tendon as being a pain generator. And so, as you get into those deeper ranges, you kind of be increasing the pressure within the tendon as well as potentially impinging the inferior pole a little bit on some of the pathologic tissue. So now you're going to be working that tendon in initially those kind of outer ranges to avoid that. You don't need massively deep ranges of knee flexion to play basketball, but you're really going to be geared towards ultimately controlling deceleration. And so what's your soleus doing? What are your glutes doing? What's your trunk control like? All of the other elements of this are going to come into rehabilitating the patella tendon, as well as the load through the tendon and obviously quad strength. Vastus lateralis is going to be key, and we found that in our G League study. Not to be a spoiler there for our data, because we haven't talked about that much yet, but vastus lateralis is really key. I think we got too enamored with the vastus medialis oblique and forgot about the rest of the quad. It seems to be important in function, and it seems to be important in terms of jumping performance, and it seems to be important in those who develop pathologic or symptomatic tendinopathies. And so, maintaining vastus lateralis is key as well. If we think about the quadriceps tendon, that pathology tends to occur in deeper ranges of knee flexion. I think, a lot of people that experience that, things like ice skaters landing from jumps and gymnasts landing from jumps. And in basketball, I've seen that with, players who land from a rebound and another player kind of lands over their back and forces them into deep range of knee flexion with the external load of another player on their back. And so there's two elements of rehabbing that. And one is eventually getting into the range that you need to have good control in those deeper ranges. And the second element, of course, there is that hip extension on knee flexion element that really is going to load the rec fem component of that tendon. And so making sure that you include hip extension, knee flexion, extension moments around the knee joint, which is again very different where you're looking in more hip flexion ranges of motion for deceleration control of the patella tendon. So even just as we move up the chain, you can see that rehabbing each of those tendons looks very different.
Nice, nice. So, uh, with all that, I want to start by asking, like, with all the Achilles tendonitis, tendinopathy, Achilles tendon pain, or like Achilles tendon tear, like a lot of the guys are actually talking about like uh range of motion in the ankle. They want to gain range of motion in the ankle, especially dorsiflexion. But you mentioned that you actually want to create stiffness. So why is that?
Why are people talking about range of motion?
Now, why do you actually want to talk about like build stiffness? I know you already talk about it, but why is there a difference between that?
Well, you don't want to end up in those very ends of range because that's we've seen consistently across the board when people rupture. Like there's no basketball is a little bit different to soccer or football, right? Where we actually see Achilles tendon ruptures in different actions. We see them actually in accelerations in football, but in basketball, nearly every single one is this false step, this stepping back to then drive forward, right? And so uh, when you look at that, they all end up in very large ranges of dorsiflexion. And we think that, limiting that and training around that is key. Basketball players don't need as much dorsiflexion as people might think. And we've looked at that one preseason when I was in Philly with positional sensors, and we did a whole bunch of like functional movements, and we looked at the range of motion around the hip and the knee and the ankle. And basketball players don't access their full range of motion as much as we might think. They do at times, no question, and I'm not denying that. And anyone listening to this, don't email me because I'm not denying that they don't get there. But I've seen people with negative knee to wall tests who are incredibly functional NBA players. They've had repeat surgeries, they've got arthritic ankle joint as a result, and they're out there night in, night out performing at an incredibly high level. So we spend, I think, way too much time and have done historically in the NBA mobilizing people's talocrural joints to. The other thing is you don't make very big gains. In an ankle sprain where there's an acute pathology and acute swelling, yes, sure, you make gains and you want to know what your preseason baseline is so that you know where you're trying to get this player back to. But in chronic ankles, if you gain 1 centimeter of knee to wall, that's like a lot, and it almost doesn't happen. Like so, where not only are we, do we think that the stiffness is important, you don't need all this range necessarily, but you also can't gain as much as you think you can, from our experience anyway, and really tracking this over time.
Nice, nice. So, the following question would be, so let's say if the athlete have some sort of like calf injury or some sort of like Achilles tendonitis, Achilles tendon pain, how do you train it to make it more stiffer?
So initially, I think we've got to think about this kind of spring-like element, this viscoelastic component. It's how you get the extracellular matrix and also the matrix within those, or the fascicular interfascicular matrix, right? Is really where the viscoelastic elements and that kind of locking of the tendon rapidly to provide that stiffness are going to come from. So realistically, you've got to put the tendon through those high velocity actions. And you've got to, initially start with high load, and then I think you drop that load back and you add the velocity piece to it. And you're going to get remodeling, you're going to get changes in that extracellular matrix and that intervesicular matrix as a result of putting the tendon through those loads. But I do lots of things from just, again, starting out with just a simple, rapid, sort of drop and rise off a step, not into end of range, and progressing to maybe like a cable step back into a cable drive, progressing to, a step down from a high box and then driving up onto another box, and really just, progressing the amount of load, but in kind of functional movement patterns for basketball, when I'm working with a basketball player. But in particular, just, really adding those types of loads.
So, just want to clarify. So we mentioned you start by like adding some sort of like rapid decel. Is it you start by that before you put into like heavy eccentric or isometric? You
No,
start.
no. I mean, if it's pathologic and it's painful, I'm starting with the isometric, then I'm going with the heavy isotonic. And then maybe I'm progressing into some eccentric and then, some slow concentric eccentric turnaround where I'm working it a little bit quicker than maybe my, temporal 3 count on my isotonics. And then I'm going into the rapid progression. I mean, you're making the same progression you would make if you were training an athlete from a plyometric perspective, right? You're not going to add that type of load without going through that sort of serial progression.
Nice, nice. So, uh, uh, another thing about Achilles tendon injury is actually one of my mentor Dan Papp said a lot of it is because the load management. And recently, like Paul George actually uh mentioned something on a podcast that he said, I don't know if it's right or if it's wrong, but I'm just curious. But like he said that one of the reason that there's actually a lot more these type of injury is because like back in the day, back in like early 2000, they actually practice a lot between games. But like right now, they actually don't have a lot of practice, probably just shoot around between games. So that put those 10 in a weaker situation. Like, can you share your thoughts on like this?
Yeah. I actually agree with PG. I think that the modern NBA, particularly the better teams, right? If you're a team with a bunch of rookies, or you're rebuilding, or you're tanking, yeah, maybe you're practicing. If you're a top 8 team in the East or the West, your practices are going to be limited, maybe unless you're the Knicks, but your practices are limited, and mostly it's going to be some individual stuff. It's going to be a walk through. The intensity of those practices maybe lower. Maybe it's more than a walkthrough when you're running through some offense, defense, prepping for the next game. But you're out there for 40, 45 minutes, and then you do some individual stuff, and then you're off the floor. So it's not that intense practice that, say, you hear Michael Jordan talking about going at his teammates day in, day out. And I do think there's something in that. One of the things we're interested in looking at is really the developmental aspect of, these tendons and how they develop. As we know, patellar tendinopathy is developed in adolescence, and you probably already got it. And I can say that we scanned so many draft prospects and, saw this pathology by the time they were 2021, right? And their draft prospects in the NBA. And so we want to understand that in the Achilles as well. So it may be what's happening through, and this has been postulated, and I've got no evidence, but it may be what's happening through those formative years. It may be the repetition of playing in those years that contributes to developing this, but then we don't end up training when we actually make it. So there's got to be a balance between the two of those. The players that tend to not get injured, I don't want to jinx him, but people like Mikal Bridges who really have gone injury free, those guys lift, those guys, lift post game. Their pre-game preparation is quite extensive. I've seen that firsthand, and so I think that. If you're not going to get the training on the court, you got to get the training and the load through that tendon somehow, and you need to get it off the court. And I think teams that do that better and manage that better probably are a little more protective than teams that don't. But I still think it's PG has a point. I think we're not training, we're not getting that load.
Nice, nice. And so I got another question about like uh especially like calf strain or like Achilles tendonitis is let's say if you have uh tendonitis during the season, like how would you handle that? Or is it possible to like handle that with that limited rest?
So this is really interesting, right? Because we looked at a cohort of players in our study that had the same injuries and went on to rupture their Achilles tendon versus a cohort that had those injuries and did not go on to rupture their Achilles tendon. And here's what we found. For foot and ankle injuries, for calf strains, players that went on to rupture their Achilles tendon returned in half the time of the players that did not go on to rupture their Achilles tendon. So, excuse me, there was something in the time for rehab and the time taken for rehabbing properly that seemed to be, very much important in the development of the Achilles tendon rupture. However, those who sat out for Achilles, tendon pain, the group that ruptured and the group that didn't rupture, the time for rehab and sitting out was identical. There was no difference between the two. So it is really interesting, and I don't know yet what to make of that, but I definitely can see that, there didn't seem to be the same stark contrast, that there was between ankle injuries and calf injuries, for example. In saying that, I really think it's a case by case basis. I really think that you have to look at, the amount of pathology within the tendon. You have to look at where the player is at in their career. Are they in a high risk age group? That 27, 28-year-old age group is much higher risk. That 4 to 5 years in the league, that type of cohort is at a higher risk. You have to look at where they are contractually. You have to look at where the team is and, standings going into playoffs, where you are relative to the season. Like all of these features are important, right? So in terms of asking how I would manage an individual player with this, would, I sit them out longer or shorter, or could they play through it a bit, their history with this, how they've responded in the past, the way that they're responding to the treatment that you're giving them, the amount of pathology within the tendon, all of that I think matters. And I think you really have to look at it on an individual case by case basis. And it's got to be a group decision. The player's got to be on board. The agent's got to be on board. The front office has got to be on board. Your medical performance team have to be on board. And I think you get everybody on the same page and you manage it accordingly. But I think the most important thing is managing it in an informed way, and everybody being informed and knowing, what we're dealing with and what the risks are.
Man, this is really awesome. I'm sorry that I put you in a really hard situation to answer all those questions. So, so the last part of this podcast, I want to talk about like return to play. I remember the last time we talked about ACL return to play. This time I want to talk about Achilles tendon return to play. Like, um, so as a strength coach, like we like probably not I'll say probably not a lot of strength coaches have the experience to have those injury or work with those injury before. So, can you kind of share like what are some benchmark that you should hit when it comes to like Achilles tendon return to play, or even like time frame?
Are we talking about tendinopathy? Are we talking
No,
about
we're talking about
returning
tear.
from a rupture?
Yeah,
Okay, okay. Because the two are different, obviously, and it's
yeah.
important to differentiate between the two. I mean, there's a lot in this, right? The first thing I'm wanting to know is what is my calf muscle capacity, and capacity is, multiple facets of capacity. First is just how many heel rises can I do, for instance, relative to my other side? We know that most tendons that end up repaired will lengthen a little bit. The more they lengthen, the worse the performance outcomes post repair. So, the more power you will lose because the muscle will basically already be, in its most shortened range and it can't contract anymore. The tendon spring is lost because of the lengthening, and you end up in this situation. There are some changes in some of the repairs with regard to where the soleus muscle inserts and the angle of the fascicle insertion there because of the repair. Karen Silbernagel has shown that. All of these are factors, but you have to start out with knowing what your capacity is. So I start out, how many heel rises can we do? You're trying to match that to the other side without compensation, inversion of the heel, flexion of the knee, forward lean of the trunk. All those are classic compensations. And we screen all of our players for this and do the same in football, soccer now. But the next thing I want to know is what is my strength capacity? So, force plate, seated, plantar flexion, in some range of dorsiflexion, as well as a standing isometric. We usually do this in the rack, plantar flexion force in knee extension. Look, there's arguments about getting the position right, and people that have done extensive testing in this, colleagues of mine, specifically refer to James Moore on this and the work that he's done with British athletics, and making sure that you're in the right range to get a reproducible and a reliable test, is important. But I think getting those numbers is really important. Then looking at, single leg power production measures. So single leg counter movement jump might be the initial place to start, but then also single leg depth jump as well, so that you're looking at single leg force production and how that looks different side to side. You're looking at jump height, but you're looking at, peak power to body weight. You're looking at peak concentric force in particular. In those situations, you're looking at rate of force development time on the plate relative to flight time, and so reactive strength index. So you're looking at all of those things on the force plate. And then I would do, say, like a 10-5 hop test, just really wanting to compare side to side. So I'm really getting my RSI and trying to compare the normative side to the other side. So all of those are important, I think. And then using the deficiencies that you find from that testing to inform where you really need to be focused in terms of your rehab, understanding the anatomic limitations of potential, changes in insertional position, and also lengthening of the tendon. But that's my big testing battery for Achilles tendon ruptures.
Nice, nice. I'm taking a lot of notes right now. So, uh, I know this is case dependent, and I feel like probably some of the athlete could probably do a calf raise after like probably 6 months, and probably some couldn't. But usually, how far along the way you would start like uh asking the athlete to do a calf raise on the injury limb?
I mean, it depends on the situation regarding the repair, depends on the surgeon's protocol, but you can be doing, double leg, resisted work through there, maybe in that 8-week mark, maybe, I mean, just if you're weight bearing early in the boot, which is, probably the best protocol to get stiffness in the tendon early. And Karen Silbernagel showed that the delayed weight bearing leads to a delay in developing stiffness through the Achilles tendon. I mean, you can be, looking at, starting to load that at that 3 month mark, single leg, and then you're potentially looking at running at 4 months. I mean, the average time to return to play, excluding the NBA, and but the average time to return to play is somewhere between 6 and 7 months. In the NBA, we're looking at, 10 to 12 months, and we tend to be a bit more conservative, and also our players are just unique individuals. Their lever arms are different. The stresses through the tendon are much higher. They're higher risk. Um, but I think, yeah, it does vary then from sport to sport, athlete to athlete, how you're looking at that. And also based on the surgeon's protocol, what you've been able to do early will also determine how quickly you can move through those ranges.
This is really cool. This is man, I love this. So, because you actually brought up an interesting topic that I was actually like thinking, like, I'm kind of confused why is as I talk to different physical therapists or like different physicians and doctors around the world, I feel like I feel like uh basketball world tend to postpone the return to play or return to performance timeline a bit longer. Why do you think that is?
Well, you're not wrong. In fact, there's data on this. There's a paper that looks at the NFL, the NHL, and the NBA, and their return to play timeframes. And I alluded to this injury audit that I did for this NHL team that got us thinking about injuries that precede Achilles tendon ruptures. And I actually looked at this paper as part of that because the NHL return to play timeframes were insanely fast for nearly every injury across the board. The NFL is about second, and the NBA is last. Uh, I think you kind of have to consider it based on, there's so many factors that go into why. I'm intrigued that the re-injury rates, in the NHL aren't that much higher, despite returning. That's got me thinking, and I don't have all the answers as to why, although there's definitely constraints, from being in a boot and different, equipment constraints. But man, those guys are beasts, and so
What
the
about
fact that
NFL?
the NFL, I think it depends on the position. Obviously, size, weight, speed, what the player has to do is important. But if you're thinking, let's take a fifth metatarsal Jones fracture, right? Let's think about that. The size of maybe a wide receiver versus, a 6'10" forward in the NBA. Immediately, the length of that fifth metatarsal, the load going through that fifth metatarsal, like it's a completely different, scenario. And so I think that there are injuries that we do need to be a bit more careful with in basketball players. The lever arms are different. You've also got to think about the demographic. You've got to think, there are differences, even in terms of kind of tissue healing, injury risk, re-injury risk across even race and age and those types of things that we need to consider that no one talks about. But those are there. We did some research that hasn't been published looking at the risk of fracture across race, age, and sex in basketball for people that present to emergency department. And we found that black athletes playing basketball across all races and black males were at much higher risk of fracture. And so, we think about that, there's some military data that would kind of back that up a little bit. And so I think we need to be aware of the demographics as well when we look at the return to play and the risks and the positional demands and the morphology of the athlete, the biometrics of the athlete. I think it's complex. I don't think we can just reduce it down to one reason.
Nice, nice. Man, this is literally one of the best I ever did. So, for those who are interested in what we're talking about today, I know you post, you're mainly active on LinkedIn. So where can they find you?
Yeah, LinkedIn, is probably the best place to find me. Absolutely.
Okay.